I've come to the determination through my examination, mostly joint mobility testing, that one of the reasons why he has limited range of motion in knee extension is because he has joint capsular tightness. His capsule's tight, I want to stretch it. What do I have to do for that? Times, how much force do I need to apply?
Overpressure?
Past the stop.
Or we can just say Accountant Born grade 3 has movement into the plastic range of deformation. Okay, so when you're asked on an exam, a practical exam, I'm doing joint mobilizations, and I ask you, what's your dosage for that? I mean, how much force you're using, and how long you're holding it for, and what direction you're going. I'm performing an anterior glide at a Kelton-Born grade 3 level of force, and I'm holding that for 30 seconds. Femur, his tibia is just off the edge of the table, okay? Scoot back just a smidge. The one thing you don't want to do, you want to be careful of as well, is the patella. You don't want to be smashing the patella up against the table as well either. Okay? From this position then, what I can do is I can support his tibia with this hand. My left hand is going to be the one to provide the anterior force. And the direction of force is going to be with what? The joint plane, which is the tibia. So I need to see, you know, depending on how flexed he is, if I'm going to do an anterior glide with his knee at 90 degrees, my force needs to be that way. If it's bent some, I don't want to push straight down to the floor then. I need to adjust my force to match in line with the joint plane. We're trying to gain that motion. We're trying to stretch that capsule. And one thing we want to do is go to where the battle zone is. So if we're trying to get extension at the knee, okay, then what we want to do is when we do that technique, we want to take that person's knee all the way to their end range of extension, wherever that might be, and then just back off a little bit, and that's the battleground. That's where you want to push, okay? So for take up the slack, what I do is I'm going to feel for which direction does his knee seem to move the most. Once I feel like I'm moving in that direction where his knee moves the most, I take him to the Kelton-Born grade 2, so I get to that end. I don't feel like it moves anymore. And now I apply my overpressure and hold for 30 seconds. Off of it, I might flex and extend the knee a few times. I might try to get a reassessment. You know, how much more motion did I get? Back off just a little bit, and then do my second round again, feeling for where's that end range? There's that Kelton-Born grade 2. That's the end. And then I push into the plastic range of deformation. A relative anterior glide, because what I'm going to do is I'm going to stabilize behind the tibia with a wedge, or in this case I'm using a sandbag, an ankle weight, okay? And that's going to prevent his tibia from going backwards, okay? And what I'm really doing here with the mobilization is the force is through the femur. So I push the femur backwards, resulting in what rotation of the tibia on the femur? Anterior glide. So I'm anteriorly gliding the tibia in relation to the femur, helping with extension. This is a relative anterior glide because the force is through the femur. And where's that joint line? And I still need to be in relation to that joint line. What I don't want to do is if I push in the wrong direction, if I start pushing straight down, what you'll start to notice is you see how he gets that osteokinematic motion and his knee's really extending? We don't want to see that, okay? We want to make sure that when I'm in this position and I am doing this posterior glide, that I really don't want to see his knee bending or extending at all. So I take him up to the end. That's the grade 2. And then I overpressure it to get into the grade 3. Feel that infield. This is probably the one I did the most for the posterior glide. It's just on the table. So again, I want to get an assessment for, okay, it looks like that's the end of his flexion range of motion. So if that's where the end is, I just want to come out of that position ever so slightly, put the leg down. And so now I know this is where I want to engage that capsule, okay? Again, joint line. Where is it? That's my direction of force. I get my elbow and forearm parallel with that position, and then I can start to just lean my body weight through my forearm, okay? Again, I can use my fingers to feel how much motion is happening at the tibia there. I'm getting a feel for the amount of motion he has first. I feel like that's the end of his end stop motion there, and then I go into the plastic range of deformation and hold. It's for people who we're trying to get that progressive flexion range of motion, but they're living in that like 70 to 90 to maybe 100 degrees. Somewhere in here, this is a great spot because then what I can do is I can just come in, let their tibia rest, and then with my hands, both hands, medial and lateral on the tibia, just push to get the posterior glide. Okay? So that at that point there, when they start getting to those levels, I started flipping people onto their back again. If the person's too far on the table for you, I can always ask Jim to just scoot back more and get close to the edge here. And just relax your leg. And so then, like, I'm just using my body's holding up his tibia, and then I've got my other hands free, you know, for how much flexion I want to do here. Okay. Now, if the person's in that 90-degree range again, I probably don't even need to hold them up anymore. A lot of times I would just sit on a therapy bench, you know, therapy stool, and then I can do my posterior glide medially or laterally, you know, and just. It's the same thing for flexion, okay? We're always going to want to go to that end range, wherever that is, and then back off of it, okay? So that's why for flexion, more so than anything else, we like, you know, sometimes we need them on their back, because if they're getting to 120 and I'm trying to get the last 20 degrees, this is not a good place for me to do this technique, because he's at 120 degrees. I physically have to push him downward towards the ground, okay? And it's going to be hard for me to control the osteokinematic motion of the leg while I'm trying to do that. At least for me, I feel like that would be. So for me, I always did this technique when a person got to around like from like 70 to like 90, 100. This was a great place to be. But once I got over the top more, I found like, for me anyway, I felt like I was compressing their joint more than I was doing a good glide. So then I would flip them onto their back again, and then I would do the other technique. Ways to go about doing this one: you can just try to stabilize the thigh all on your own, which is fine. Belt down the thigh. So that way I can just be back here with both hands and pull, okay? Stabilize and just pull above the malleoli is another way of doing it. Fine. The idea, remember, behind the distraction, it's always 90 degrees to the joint plane. The tibia itself is 90 degrees to the joint plane. So just pulling the tibia longitudinally, you'll get that distraction force that you're looking for. If I'm doing it as a joint mobilization technique, I might even, if it's possible, get him towards that end range. And so, I mean, I could be here and do like a lift if I wanted to, or belt him down and just do a lift if I wanted to. If it's for pain reduction and just minimal, just oscillatory, then it could be any position I want. So it might be that open pack position. Okay? So again, we're introducing this as mobility restrictions due to the joint capsular tightness. When we decided the joint doesn't move because the capsule's tight, we need to do joint mobilizations. Those techniques in and around 0 degrees, you can do the medial glide, and it's just taking the assessment but then making it a mobilization. So stabilize the femur, you might need to do that with your other hand. While your mobilizing hand does the medial glide technique, okay? Get your elbow down nice and level. With my inferior glides, notice what I do is for my forearm, I bring it down to the level of the thigh. So again, I'm pushing with my forearm. The forearm is the direction of motion for me. So I can see, you know, find that end range, go into the Kaltenborn grade 3 if need be, okay? For the superior glide, again, I don't want to do it with my hand up here because that's going to lead me to want to even create some compressive force. And so what I do is I just bring my forearm down to the level of the tibia there, maybe just slightly off of it, depending, you know, the line. But the other thing is you can do the patellofemoral distal glide with the knee bent, okay, 90 degrees or anything more than that. To me, the patellofemoral joint is so down and into the joint, it can be a little bit tough to feel any appreciable movement. So when I couldn't feel any appreciable movement myself, I would just back them off out of that and then just do that glide there. But so now remember, you know, my joint line, my joint plane is the patella. So I need to see what's that joint plane look like, and that's where my forearm needs to be. It needs to be in that line. between the thenar and hypothenar eminence. Okay, these fingers are on the patellofemoral joint line, so I can feel for the patella moving on that. And, again, we talked about go to the battleground, back off a little bit, so I want to do the same thing for the patellofemoral joint. Further and further degrees of flexion, you're getting closer and closer to the closed pack position. Right, the patella is sinking into the intercondylar grooves. For the posterior glide, can be done with the person prone. Okay, you're just going to get your thenar eminence on the fibula, find that line of force, and then you can do the, find where the end of grade 2 is, go into grade 3 and hold. Okay, for the anterior glide, you can, if you want to, come forward and pull. The issue with that is be very careful with the fibular nerve, okay? Also, it can be a little bit tough to get the posterior fibula with your fingers. So what I always did clinically was I had the person lay on their side, if you go on side lying. So even from this position, first, I can still do the posterior medial glide. What I have to do is come to this side of the person. I can find the fibula head. I can have my fingers on the joint line, feeling for that motion. And again, with my hypothenar eminence, just find that posterior medial glide, go to the end range, and then go into the plastic range of deformation and hold it. For the anterior glide, I would come from the front, palpating, and I would even have to get down on the knees sometimes. And so, Jonah, because they're filming, just come backwards towards me. Let's just, I might even come down on a leg, because I want to go that anterior lateral. And so again, I want my forearm in that direction that I'm going. So this gets me into that position. And I can get my hypothenar eminence right on the fibula head. I can stabilize the tibia with this hand, and with my index finger be right on the joint line to palpate for the motion. And then do the anterior glide. And
it's convenient, use it,
yeah. And again, so stabilizing that tibia is important. Okay?